Welcome to Hope for Med.
Hope for Med.
Welcome back to the Hope for Med podcast with me, Dr. JB, as your host. Today's featured guest is Dr. Will Harvey. He has been in healthcare in various clinical and executive roles over the past 20 years. In achieving his RN, MBA, and doctorate in social service, Dr. Will brings a unique perspective to the field of community health. Welcome, Dr. Harvey.
Thank you, Dr. JB. I appreciate you having me. I've been looking forward to the conversation.
So, Dr. Harvey, please tell us, what brought you into healthcare in the first place?
Oh, geez. I'll try to give you the Cliff Notes version. I've always been into healthcare, and as cliche as that is, I was diagnosed with asthma, pretty much, as my mom likes to joke, like at birth, like right out of the womb, you had asthma. It was really bad when I was a kid, kind of coming up, and my mother sent me to this asthma camp in Southern Maryland, and as geeky as that sounds, it actually really helped me in the sense that like the nurses in particular and the pediatricians were absolutely phenomenal. So when I really started to understand, get indoctrinated to what your career path was going to be, I just gravitated towards medicine. And I was very fortuitous enough to go to a pretty progressive high school in Prince George's County, Maryland, where it's like kind of a pre-college, pick electives kind of a deal. And I just picked the social services track with medicine and kind of went from there. Then after I got my CNA and then eventually became an emergency nurse, like this was just, it was almost like it was predestined.
And how long did you work as an emergency nurse?
So for about 10 years at the bedside, I mean, I was an emergency tech before that, and then an emergency nurse after. And then eventually I wanted to have a bigger impact. Emergency medicine is profoundly rewarding in this sense, but as you know firsthand, it can be severely draining. And in trying to look for ways to really impact my community, I entered home health, which has been a great community and public health arm that is finally starting to get its due, but a well-run agency can have a pretty big impact on the community at large.
Indeed. And when you were in the emergency department working as an ER nurse, did you ever experience any symptoms of burnout?
Pretty much all of them. I mean, it's, what I find interesting, well, let me answer your question first. So yes, I mean, I was lucky enough to be night shift, which if you've ever spent 2 seconds in the emergency department, there's always that internal struggle of night shift versus day shift. But in working night shift, we were kind of a band of brothers and sisters and would help each other and try to hang out and become friends outside of the emergency department just to kind of find ways to deal with some of the hard things that we were going through. But as good as your support system is, nothing's foolproof, right? You're seeing people dying on a daily basis. You're seeing overdoses and gunshot wounds and cases of abuse, and the police department bringing in this convicted felon, and you find out what he or she has done. I mean, you'd have to be made of stone for it not to take its toll on you. And what I find interesting when we talk about burnout, at least recently in some of the podcasts and readings that I've listened to, it's always been the context of your job. I've always thought that really interesting. Like as a physician, you're burned out, or as a nurse, you're burnt out, or anything like that. It's rarely, at least in some of the things that I've listened to, it's rarely talked about what that person's life is outside of work that may be adding to it, right? I mean, when I first started experiencing, I guess, my first burnout, if you will, mid-20s or so, new into the career, trying to make a name for myself. And as much as I'm trying to really gravitate and do all I can for my job, I've got this life going on. Your spouse is going through something. My mother's going through something. I try to have a relationship with my dad, trying to worry about my own health issues. All those type of things, it's like a perfect storm that adds to this burnout. So I've always just found that interesting that we talk about burnout. It is typically first talked about, okay, what do you do for a living? And then that's the reason that you're burning out. It just seems to be rarely talked about on what life events that are weighing on this person daily while they're working that's contributing to that burnout. But yes, I mean, I would easily say with all humility that I've probably burnt out, quote unquote, 3 or 4 times in my career. And I say that without shame. It happens when you really give yourself all to your profession.
Going along those lines about why is it that burnout is always just affiliated with your workplace? Because if you look at the definition of burnout, like the way that it's classified, ICD-11, burnout's a syndrome conceptualized as resulting from chronic workplace stress. And so that's why there's always emphasis on the workplace. The way that burnout is conceptualized, at least to me, is that it's not something inherently wrong with the person. I think that there's different schools of people that some people don't like to use the word burnout because they feel like it's a negative connotation. And instead, other words are more applicable, like moral injury and things like that. But for me, whenever I talk about burnout, it really is in the context of your occupation, according to the definition by the WHO. That's when I
And
use that word, that's what I'm stressing. How does your work, your chronic stress that you're experiencing day to day cause or contribute to these symptoms of burnout? But to your point, it is multifactorial.
I definitely think so. And it's not to say, I mean, your job takes up an extraordinary amount of time in your life, not just from when you clock in, from when you clock out, but if you're a professional, paraprofessional, or truly embrace the concept of having a career, that's all the schooling and training that you've gone through. That's after hours thinking about it and prep. And if you're a nurse or physician, the documentation you have to do that maybe after hours. No, I 100% get the time consumption and why it would be so affiliated. But then I guess I challenge the definition, if you will, to think about all the ways or some of the mainstay ways that we ask folks to combat burnout, seeking emotional support, setting boundaries with others. Don't adhere to these new commitments that you're taking. They're typically all types of things that have to happen outside of the workplace, right? In your quote unquote personal time. So I think it's hard to just say that it's just workplace. And I know you're not saying that, it's going to bleed into your normal life. And then I think subsequently, your normal life stressors are only going to add to it. And if you are truly one that, the buzzword is work-life balance, if you're truly one to try to have that, you're going to try to dedicate yourself equally to your family, friends, as much as your job. And if you're doing that with any type of empathy and compassion for your families and friends, their struggles and what they're going to go through in the course of their life is ultimately going to weigh on you. And I think add to that burnout, if that makes sense.
Yeah, no, that's
Yeah.
completely accurate. And so I know that you mentioned my first episode of burnout. And so you've experienced numerous periods of burnout in your life?
110%. So honestly, if I could really, really trace it back, the first probably was even before I became a nurse. So I don't think the story of how I became a nurse is necessarily unique, but it was filled with a lot of hard work. I was an emergency tech for an emergency department in Montgomery County, Maryland, and I went to nursing school in Johnstown, Pennsylvania. And I did both at the same time. I would literally go to nursing school Monday through Friday, get out of nursing school in clinicals, change, drive the 2.5 hours south from Johnstown to Rockville,
Wow.
clock in for that overnight shift. Once I was done with that at 7 a.m., either crash at my mom's or crash in my car, come back in, shower, work that next overnight shift, and then drive back up to Johnstown. I did that consecutively for 2 years, and I would be remiss if by like the end of the first, as much as successful as it was, I was exhausted. I
Hmm.
mean, I was just, I think as part of burnout, you're taking inventory of why you're burnt out. And it's like, do I just drop this huge burden and let me just figure out another career path? Or is it just worth sticking to for the end goal? So when I was in nursing school, that was probably the first bout. And the only way I think that I really got through it is you just try to keep your eye on the prize. Like I was very blessed to work with some great nurses and physicians that were encouraging me along the way. After I graduated, like we talked about, really trying to become the best person and nurse I could be, whether it was trying to better my IV skills or EKG interpretation, whatever it was, fastest triage person, that inherently puts some stress on you and trying to get that knowledge and that overload there. So probably maybe after 2 years straight at the bedside and seeing some really traumatic cases that really, again, on the drive home, it was more than a few times that I would pull over and maybe kind of just really break down over some of the stuff that I had seen the 12 hours before.
Hmm.
And then eventually, in addition to wanting more and really wanting to focus on community and public health, deciding to leave the emergency department, I did feel like a weight was off my shoulders. And the burnouts have been less since then. But definitely my times in the emergency department were both physically and emotionally kind of taking a toll on me.
And so how did you recuperate from those experiences of burnout?
I think kind of probably the best way that I could think to say it that will probably be the most relatable to your audience is just putting things in context. I'm not saying that it always comes with age, but as I sit here today in my mid 30s, I don't think I have the same perspective as I did in my mid 20s, right? I understand what's a bit not only more what's important, but how I fit into the overall goal. And when you're not trying to overextend yourself and do too much and put too much on your shoulder, you kind of keep things in context and understand when you fit. 10, or so years ago when I was at the bedside and really just, we're shorthanded on a Friday. Like I've already worked like 3 12s. I'm ready to be done. I'm walking out and they're saying, hey, we got a couple call outs for tonight. Can you do it? Me now would be like, you know what? I'm sorry. I understand you're short, but I can't do it.
Mm-hmm.
Me 10 years ago, it was like, all right, I'll see you in 12 hours. Right. Let's just, you learn your limits. I think it's the strength of any man or woman is not knowing your strengths, it's knowing your limits. And I think as I sit here now, knowing my limits prevents me from putting myself in a situation where I'm overextending myself and then leading to more burnout.
Okay. And so in the news, we're hearing a lot of talk about seas of nurses leaving the field of medicine.
Hmm.
What do you think is contributing to that?
So many factors. I mean, I know most of your audience is most likely, and obviously you're an emergency physician, you know this firsthand, but the nursing shortage is well documented, even before the pandemic, for so many reasons, not just pay or lack of teachers to actually teach the new crop of nurses to come into the field, but scarcity in nursing schools. They're not popping up on every corner like some vocations. So that was already an issue before the pandemic. Now that we're 2 full calendar years basically in the pandemic, at first, nurses were heralded as heroes, and all nurses, I believe, are. Every emergency physician, every physician, every allied healthcare professional is a hero in their own, from the radiology tech to the custodian helping on the night shift. And that was really put front and center in the beginning days and weeks and months of the pandemic. Since then, though, I would say easily over the past 18 months, I think it's hard for any healthcare professional, especially one who dedicates themselves to education and staying abreast of what's going on around them, to ignore the rancor and vitriol that has surrounded the profession of nursing. Basic rudimentary science and that we've all learned and adhered to and believed in is now being questioned by, let's just say, those that it's hard to, to understand why they're questioning it. And so if I a seasoned nurse or a seasoned physician, it's one thing to withstand that barrage and to kind of stay focused. But how does all that negative, toxic rhetoric affect those who are on the fence of joining this profession?
Mm.
Right? Like if I was a new, just doing, some undergrad work, a bio major at the University of Maryland or something, I don't know what I want to do. A quick Google search on the perspective of nursing right now, maybe I'll just shy away from that profession.
Mm-hmm.
Right? There's not a lot of positivity still around us and believing in our abilities to help humanity. And as much as a big like statement is it, that's literally it. When we get sick, we are fortunate enough to live in a country where we can walk into any ER, urgent care, and to get treatment. And the only way that we're able to get that is by the people in those scrubs that help us when we need it. And if those people start dwindling down, we're in a lot of trouble. So I hope that sooner rather than later, we can kind of turn the tide and prop this profession up the way that it should be, because without it, our entire ecosystem, if you will, is pretty much going to crumble.
Mm-hmm. Mm-hmm. And so how could we turn those tides around?
I mean, I want to say that it starts with us, but I mean, as you and I talk today, I think we know our value. I still work with fantastic physicians and nurses. It has to be wider. It has to be some of those injecting this toxicity into society to come to some type of realization. Like, I don't know if people say this type of thing for it to be sensationalized and to grab a headline, but at some point we need to put those egos aside and realize the damage that is being done at society at large. I'm not sure if this is more of a political movement, if it's more of grassroots, but there needs to be more advocacy for nurses. I mean, Obama administration did a lot for nurses and allied professionals. Obviously, our current administration does what it can when it can to kind of shout out the nurses and physicians, but it needs to be more widespread at a local level to promote kind of more community activism to get into our profession, because that's typically what happens. I mean, I live in Baltimore County now. You enter the Baltimore County, School of Nursing. Typically, when you graduate, you will treat Baltimore County residents. It is typically on a local level. So if
Mm-hmm.
we could kind of start that positivity, I guess, more on a grassroots, hopefully it would pay dividends on a national level.
But what about retention of the ones that currently are? Because if you feed people into the system, but you can't keep them in there, then is it beneficial?
That's a fantastic point. So retention's big, and I was talking with a colleague just last week because I'm not sure if you follow some of the, big trends of this as far as travel nursing, but if you're like a staff emergency nurse somewhere downtown, you may make 60, 70, $80,000 a year. If you're a travel nurse and willing to go from Maryland to Minnesota to California to Florida on a whim, you could probably make $100,000 in 6 months. Pay, sadly, is always going to be a driving motivator, and it's hard for somebody to stay loyal to an organization that they've been with for 5 or 10 years making the same salary when this nurse coming from Maine can make double their money in 13 weeks. So I think first you have to make people right financially.
Mm-hmm.
Then it's what other things do you offer to handle, like we were talking about burnout before. There are still some as organizations that don't necessarily realize the impact, the psychological, the mental impact that being in this profession takes. The ones that do, you kind of invest in that. So giving the opportunity for mental counseling free of charge to help employees through these hard times, financial planning and services, obviously top-notch benefits and healthcare. Like you have to invest in a person kind of holistically. But honestly, what really speaks, or what I've seen, even anecdotally, is the pay. I think as a whole, with as important as a physician's job is, a nurse's or any allied healthcare professional, there has to be a rise in overall pay to drive that retention of those people who we rely on every day.
Seeing how much people are able to make as travelers and how it's like 2 to 3 times, how
Mhm.
much would the pay have to increase for the whole traveling nurse system to dwindle down?
I mean, think about what the cost is if it doesn't. When we don't invest enough to get new people into this profession, because I can't speak for you, but I know I don't plan to work forever, right? There's a finite time on every healthcare professional's like career, period. Whether it's you get burnt out, you physically can't do it, or you simply want to do something else. You want to get into, I don't know, flipping houses or something. So we're talking, depending on the market and the population, we're talking pay increases of 10, 20, perhaps even 30%. I mean, think of some of the sign on bonuses. Literally, not just this morning. Hospital system in Pennsylvania, I won't say the name, sent me a text message because I was on their mailer, offer for registered nurses to come on for a salary plus a $20,000 bonus,
Wow.
okay, for a 1 year commitment. 10 years, hell, 3 years ago, that was unheard of. Absolutely unheard of. When I first signed on for my first emergency department, there was no sign on bonus. It's like, there's the bathrooms, here's your badge. Are you ready to work? There was nothing. There was
Mm-hmm.
absolutely nothing. Now you can get 20 grand for a 1 year commitment. Who couldn't do that? I think if we're doing that for new hires, retention bonus equal or greater than that should 100% be on the table because healthcare, as you know, as much as we need new folks to come in, it is the older, the senior, the vets there that are in charge of kind of really bringing them on, really taking, what they learned in the classroom and applicable to bedside. It has always been, I've learned from some of the best vet nurses in my career. I'd be nothing without them. And it's going to be the same thing from generation to generation. So retention bonuses, increasing their pay is one of the first major steps to get people to stay where they are.
Yeah, and then along the lines of whole care of your employees, I think some healthcare systems would say, well, we already have that. We have employee assistance programs.
Sure. And a lot of places do, even in home health. And I work for a couple national companies, they do. But if you really ever needed them, I don't know if you've ever been in a situation where, or in a company where you've actually had to take that on, there are limits, right? Even for the last company I worked for, which will remain nameless, we had an EAP program, which was great, but there was a limit on how many counselings that you could take. So just off the bat, think about, I don't know, times through severe mental health challenges or just going on something in your personal life. Do you think that can be solved in 3 conversations? Absolutely not. Now, of course, they're going to refer you and this, that, and the other, but for me, if you're establishing a rapport with someone and you're really working towards something, turfing them after a few sessions to me doesn't seem to make a lot of sense. So again, I think some of these EAP programs and employee engagement programs can be expanded so that there doesn't seem to be such a, I guess, finite time frame on them. Like if we really want people to stay with us, forever till the sun burns out or they decide to retire, then the benefits that we offer should provide that type of stable, concrete support as well.
Very, very valid point. And so now you've transitioned out and you are working in the home health care arena. What's that been
Yeah.
like for you?
Initially, it was a culture shock. It was just different. It was, as you know, emergency medicine is very much a place of instant gratification or instant failure. Like, either solve this problem now or I'm going to fail in 2 minutes. That's it. With home health, there's longer term goals, which I really like in the sense that you can see somebody progress, whether it's over a few weeks you may have them or 30 or 60 days, like a certification period. Like you can see somebody freshly coming out of the hospital with a total knee or total hip replacement and be a part of a team that is really going to get that person back to functionality, or anybody from wound care to IV therapy to anything. You can see them ideally fully integrate back into the society that they want to be in instead of necessarily in the confines of a hospital. So that's what's been really affirming after I kind of learned some of the ins and outs of home care. Now, being in charge of an agency that serves a very wide dynamic of folks, and proud to say most of the employees that I serve from the West, Central, Southern African region. So that cultural understanding of not only my employees, but how it integrates with those that we serve. It's been fascinating. And I'm a huge advocate for home health just because of the cost of our healthcare system, which when we get down that rabbit hole, home health is the way to go. For somebody to heal and age in place, that's kind of the next biggest wave of healthcare, if you ask me.
hmm And do you find that through your services, you're able to prevent them from having to come back to the emergency department?
Absolutely. Nothing is foolproof, right? Somebody is, unless you're truly providing 24-hour care, which is always some barriers to that. Certain insurances don't pay for it. The patient may not be able to pay for it, all this other kind of stuff. So you can't prevent everything. Somebody's going to inadvertently put down their walker the wrong way, trip and fall. Something's going to happen. But yes, with that type of diligent, hyper vigilant type of care, you can, and with highly trained staff, that's another thing that we can talk about with continuing education, you can 100% get any agency's rehospitalization rate down to 5%. And think about keeping the math simple. If you had 10 agencies in a county treating a substantial portion of seniors and all of their rehospitalizations rate were 1, 2%, you've inherently pretty much kept a large subsect of the population out of the emergency department, safe in their homes, compliant with their medications, fed, clean, and dignified. So rehospitalization programs and ways to prevent it are a huge subsect of what I do.
And in terms of the home health care, I've heard a variety of things in terms of the services that are provided to individual patients. Could you speak more about that?
Sure. So it really just depends on what avenue of home health. So, for instance, to keep it super simple, there's skilled care, which is typically a Medicare certified agency, somebody coming in for a short, comes to you with a short need, like wound care, maybe stage 3 that we're trying to heal, and you would have them for a couple of months. You maybe need a nurse, depending on where the wound is. Maybe there's some mobility issues, so you get physical therapy involved, maybe occupational therapy as well, and you slowly but surely progress them and try to handle the most acute issues that they're dealing with. And then, of course, they ideally heal, get back into society, good to go. Then there's more long term on the other side, like what we call kind of private duty nursing. Those are typically paraprofessionals, CNAs in most states. Virginia does personal care assistants. Either way, they're typically trained for helping with ADLs, homemaking, preparing meals, medication compliance, depending on their licensure. And that's more, I think, of a preventative side of it too. Like skilled care, something has already happened that we're trying to fix. To keep it super simple, private duty, we're trying to prevent you from going into the hospital. So you've got a 45-year-old, male, elderly mom. He's got to work 60 hours a week, can't be everywhere. Mom lives with them. He'll hire a private duty aide for 8, 10, 12, maybe 24/7 to help with his mom. And in doing so, to kind of assist where he cannot, we keep him out of hospital, keep him safe. So those are kind of the two big silos that exist. And it kind of goes on from there with IV therapy, speech therapy, other kind of things in home health.
And do you find that insurance normally covers these services, or is this more out of pocket?
For private duty, there's a lot of out of pocket. For skilled care, insurance does typically after acute care hospitalization or with a physician referral, will cover a portion of home care. If you're a Medicare recipient, Part A does cover a bit after acute care hospitalization. There is no acute care hospitalization. Part B does cover to some extent. But typically for private duty, the preventative side, which is what I think kind of drives public health, and not just from an elderly standpoint. I mean, preventative as far as like all of us, no matter what your age, getting your physicals and the whole 9 yards. Insurance is not really caught up to that yet. So the majority of the clients that I serve in my agency are private pay.
And so, if somebody were of a lower socioeconomic status, are there any resources for them to be able to tap into to fund private care?
There are, but that's where I think we as healthcare professionals and public health advocates can really kind of champion for them because there are resources. But even speaking from my seat, they are a bit convoluted. I work for a nonprofit that truly we have teams, I mean, true teams that not only apply for grants on behalf of the agency to give those funds to those in need, but help those and connect those of a lower socioeconomic status with social workers for the sole purpose to navigate some of the bureaucracy that exists state by state to get either Medicaid dollars or funding and grants that are available to them to pay for services. So, in order to really evolve this, we need to develop constructs, whether it's state by state or on a federal level, to make access to funding a bit easier. But some of the hurdles that one has to jump through are very tough without a professional. And if you add the complexity to how to navigate that system for somebody with maybe a cognitive deficit or maybe perhaps autistic or any type of like traumatic brain injury or any type of functional immobility, it becomes that much harder and it's practically impossible to do it on their own. So they will reach out to an organization like mine for help and guidance. But as much as we have a team of people always willing to help, we are far outnumbered as far as those that we physically can get to help and those that need the help. We need help, if you will,
Mm.
to make this process easier so we can kind of get our services to everyone who needs it.
So, when you began your journey in healthcare, did you ever imagine that you'd be doing what you're doing right now?
To do exactly what I'm doing, no, because I would never, I would never pretend that I could predict the future. But I am, everything that I've done up until this point has been affirmation of why I chose this path. In the emergency department was some of the greatest times of my career and gave me a good foundation. And I knew I was helping my community, but I looked at it more as like I was just putting out a fire within my community. There was an emergency, I reacted, okay, we're great. And then another AMBO rolls in, you do it again, bam. It was like that type of thing. And now in this setting, I look at it like you just kind of said, in a preventative way. So I'm actually happier, if you will, if I can use that word, that I've gone this path because I feel like the reach that I have and the impact that I have in my community is far greater. And ultimately, when I first started as a nurse, that's what I was trying to achieve. So I didn't know what it was going to look like at that point. But now, as I sit here today, I'm very much proud of the work that me and my team have been able to do in this community.
And you've been really successful in terms of climbing up the leadership ladder.
Yes, yes, very fortunate. I tell my team all the time, I think I'm allergic to complacency. Like I just can't do it. So when I started as an RN, like I'm sure when you started as a physician, you're just really just trying to get your feet underneath of you. So God bless the people that like come straight out of school, start their job, and go right back into school. I couldn't do that. I just had to, I wanted to really get some of the tenets of emergency medicine under my belt. But once I felt comfortable in going back for my bachelor's, that was of course the next step. Most of our nurses that I've worked with, yes, that's logical. And thank God for online classes where you can do it 2 in the morning, 3 in the morning, 7 at night, that kind of thing to progress as well. But after I entered home health, I was fortunate enough to go to Texas and help run an agency there and really started to understand more of the business part and sit in some real high level conversations about how the money allocation and resources allocation plays a huge factor in how much you can impact your community. The business aspect was just calling to me. So I was fortunate enough to get my MBA and really bolster my business acumen so I could have a bigger seat at the table, and all the while still working on my doctorate for human and social services. And the reason that I went through that kind of route is just because I really wanted to be well rounded. At that point, I was already in community health, and I've seen some of the roadblocks that exist for those that, and it's nothing against it, but I've seen some of the roadblocks that those who just stay on one track. I've met and worked with some of the greatest nurses in my career, but those that strictly go RN, BSN, MSN, for whatever reason, when they are in boardrooms or in high level conversations, some of the powers that be don't think that they can have a true business conversation. They think that they have their heart on their sleeves and purely addressing this from a nursing aspect. And I've seen their opinions get shut down. And I don't want that to happen to me. So I went the nursing track, developed my business acumen, and got my degree to quote unquote prove that. And then Community and public health has a lot to do with battling the social determinants of health. So, getting a terminal degree where I felt I could master that and understand it as best that the academia could teach me, that's how I figure I can do what I can to make sure that I'm really contributing in the role that I am. And then with that, to go back to your central question, with that has typically come a promotion or recognition from the organization I'm in, and they've allowed me to lead.
And do you have any concerns about the advancement of nursing and clinical executives being affected by the current pandemic?
I do, just because I think about my own journey in the sense that starting out in my early 20s, and I never really, like I said, I didn't know where my path was going to fully go, but I was able to be encouraged and poked and prodded along the way to get to where I am now. If we have less and less people even entering this profession, it's less and less people that are going to encourage that younger nurse to keep kind of going through. And then what the pandemic kind of highlighted bright and center that we've all known for years is how dependent our healthcare system is on the service of those people of color. And if those people of color are not only discouraged from entering this profession, but financially not able to even enter this profession or advance in it, you're not only going to have less and less people in the field in general, you're going to have less and less representation in some of these high level meetings that help dictate funds or resources or allocations that will get more and more people in the profession, if that makes sense. It's almost like we are purposely bottlenecking what we're going to be able to do as far as impacting our community. So, I mean, I'll do whatever I can to support this locally, but that's where that needs to start. We need to start advocating, whether it's at a middle school, high school level, the benefits of a service in medicine so that we can really bolster our numbers.
And why do you think people of color are being discouraged to enter into the field of healthcare?
That's a really, really good question. I think it's some of the same reason that all of us are a bit discouraged. I mean, in going through the pandemic, like I said, 2 full calendar years even beforehand, and seeing how the perception of health has changed just in a few short years, and some of the yelling and screaming, no one wants to deal with that, no matter what your color is or what your background or ethnicity. Nobody wants to deal with that. But if you think of a race or even religion or ethnicity that has been so disenfranchised already before there was such thing as the coronavirus, why would you then purposely want to sign up for more headache? Your life has already been hard enough
Mm.
coming up maybe properly in the inner city, maybe not having enough food on the table or maybe not sure of shelter. And then you're now going to enter a profession where, as noble and humble as it is to serve another human being, you're wondering in the back of your head, when I go to work every day, am I going to get spit on or kicked in? Or like I'm trying to give simple medical advice and they're telling me that the science isn't real. Like, we framed it in certain aspects of the media where signing up for this is signing up for a lot of headache. And that didn't always used to be the case. Nursing still is. And not saying other aspects of medicine, but as a nurse, and that's what I'm going to advocate for
Hmm.
too.
I understand.
you know, being a nurse is truly one of the greatest joys I've ever had in my life, and I want other people to experience that. But as much as I've been called so many words at the bedside that were probably not appropriate for your podcast, I wouldn't want that on somebody else either. I think we have to respect is a trigger word these days. But I think as a society, we need to get back to respecting that profession, and then maybe we can draw more people, not just of color, but of all races, back to it.
But what you say in terms of your experiences at the bedside, this is pre-pandemic.
Very true. And so it's been there. It's just I think it's gotten worse. I
Hmm.
think the some of the negativity and vitriol around the vaccine and the virus has just given those type of naysayers and those who feel comfortable treating those with disrespect and prejudice and bias. It's given them another arrow in their quiver to attack this profession. And one very much of a mindset of bend don't break. But sometimes when you're truly attacking like the science and the stuff that really supports our profession and allows us to treat people as efficiently as we can, that might be the straw that broke the camel's back at some point.
Hmm.
It's one thing to attack me, remember at the bedside for my color. Okay, I'm still going to help you. I mean, you're you're a blank, but I'm still going to help you. But then when you're really just attacking who I am and what I believe in as a clinician too on a daily basis, that's just really hard to get over.
Mm-hmm. Hmm. And these experiences are different in home healthcare.
No, because as long as we're dealing with people, people are inherently flawed. But I have certainly found, granted, I'm only just comparing the emergency department to home health.
Hmm.
I've certainly found those recipients that we're dealing with in home health, whether it was skilled or now in private duty, much more receptive. I mean, I can't even count on a weekly basis how many thank you cards or calls of appreciation. So and so helped my mom. I'm so glad that we chose your agency. I couldn't do this before, and now it's 4 months later. I can do X, Y, and Z thanks to this nurse or that PT. I got to tell you, and you probably would maybe think the same. I don't remember too many thank yous in the emergency department. It is a thankless job. I mean, that's what we sign up for to some extent, but I don't recall too many of those when you've helped somebody who's maybe done a bit too much cocaine, or maybe it was kind of like tripping out on this thing. Like, usually are not getting those accolades. So just that appreciation can help someone, especially who's been in this field for as long as I, come back the next day and keep doing a good job. Everybody, no matter what you do, whether you are putting together sandwiches at a Wendy's or whether you are in the world's biggest healthcare system, everybody wants to feel valued for what they do.
And even if you don't get that appreciation from the patients, which is true, the emergency department, you don't get a lot of thank you.
No,
Uh, the person comes in unconscious when they arrive and they get discharged later. They don't know what happened. They don't realize they came through the emergency department
precisely.
and what the ED team did for them. But getting that appreciation somewhere. So if it's not coming from the patients, then coming from administration, the genuine appreciation.
Correct. Yeah, not just we order a couple of pizzas for the night shift and they're in the break room, but true, genuine appreciation where, and that's to go back to kind of the affirmation, I guess, on where this is. I find that now, and maybe just I'm in management, maybe I just have a different perspective, but I'm able to talk and connect with my caregivers, my nurses, my staff a little bit more. And in doing so and building that bond and trust with them, I get to find out what actually is driving their why, their motivation, and I can adapt my leadership style or things that I plan for the team to them. And then I would hope that makes them feel more appreciated and them come back to work. So there just is, granted, you can't compare. I love the team I had in the emergency department. I will always, I'm still friends with them to this day. But being in home health and having that kind of arm in community and public service, there's a different type of family. There's a different type of synergy that really supports one another.
And why do you think you're able to better connect with them?
I think we have more time. Time is the biggest thing we can't control and probably the most valuable thing on this planet. In the emergency department, it is rush, and rightfully so. It's an emergency, right? I mean, they're not all emergencies, but in general, it's an
Hmm.
emergency. There's time, there's algorithms you're following. You're really doing things methodically and quickly to get that goal to save that person's life. So that is the job. But when you're in home health where things are a bit slowed, you not only have time to take care of the patient, you have time to take care of the nurse. They're a human being too. Just like we began our conversation, they are maybe are going through things in their personal life that are going to distract them from day to day. And in the course of any 8 to 10 to 12-hour day, I have the time to connect with my staff on a personal level to find out what's going on in their life. And before I maybe fly off the handle why these hours were down or why this was charted this way, I can connect with them and find out what their motivation are, what's distracting them on their personal life, what kind of gets them up in the morning, and like I said, tailor my thoughts and actions to them as anyone should when they truly respect those they work with.
How does your experience as a bedside nurse affect your leadership?
That's a very, very great question, and a story that I've told many times. So I think it's all in the people that I've met, not necessarily in the experience. The experiences I will remember forever, but unfortunately, there are folks outside of medicine that have had horrific experiences that have altered and changed or improved their lives. The people that I work with at the bedside are probably my biggest influencers. There was a nurse that she has since passed, but she's probably one of the greatest influences on my life. Her name was Jean Smith, who was probably the best charge nurse. I'll go toe to toe with anybody. The best charge nurse I've ever worked for, and arguably in the planet. She knew it all, but it was not with any type of hubris or arrogance. She just knew it all. And when she trusted you, when she put you in the code room or said, you're taking triage, you instantly just got a boost. You're like, she thinks I'm ready for this. Okay, then I can do it. And building up that type of reputation and knowledge base, that's what I aspire to be as a leader, so that when I put those in charge and I don't need to micromanage and I'm giving them the autonomy to sink or swim, they are boosted by the confidence that I have in them, because that was impactful to me. just her words. If our code room was called room 6, everybody does it a little differently. When Jean looked at me, or if it was on the schedule, Will, you're taking room 6. Oh, wow. Okay. I'm ready for prime time now.
Mhm.
I want that same type of gravitas, but the only type of way that you can do it is with humility and experience and knowledge. And ideally, the day that I get to kind of tap somebody and give them that power, I'm hoping that they feel the same confidence in themselves that I did.
That's some high praises for her.
It was awesome.
So, in closing, Dr. Harvey, do you have any final words of wisdom for my listener?
Honestly, aside from the golden rule, I would honestly just ask everybody who listens to this. I know hopefully you have like a wide array of listeners, both medical and non-medical. I really just encourage people before they act. I tell this to my staff all the time. So if they end up listening to this, like, okay, here he goes again. I really think it's important for those before you act, before you pick up the phone, before you send an email, before you go order something at a fast food restaurant, think about for 2 seconds what that other person has potentially gone through in their lives, that your energy doesn't have to negatively match theirs, that it's okay to be humble and appreciative and respectful and to say thank you. Now, as broad as that is, I truly think if we adopted that in all aspects of our lives, but especially adopted that in medicine, and especially over the past 2 years, I don't think you would see some of the articles and studies that have come out talking about the decline in doctors and nurses that are projected over the next 5 or 10 years. Simple thank yous, and thank you for helping me. Thank you for helping my mom. I know this is hard on you. Sharing a cry together, things of that nature can get people to truly believe in why they chose to do what they do. So that's how my mother kind of raised me. That whole treat others how you want to be treated. It's the oldest line, I think, in the world. I think if really people took that to heart and to mind, then maybe we could save some careers in addition to saving some lives.
Yeah. Who says a doc can't rap? DOCTORJB. The greatest doctor to ever touch the mic. The greatest podcast ever broadcasted or pre-recorded. Come learn some. Each one teach one. I'm done.